Okay, so moving on to respiratory failure. So our concept is gas exchange 1. We've got our interrelated concepts: acid-base balance, mobility, anxiety, infection, perfusion, nutrition, functional ability, and fatigue. And then our exemplar that we're going to be talking about in this lesson is going to be acute respiratory failure. So our learning objectives. So acute respiratory failure, so this can result from inadequate gas exchange. So hypoxemia would be a decrease in your arterial O2, so your PaO2, what we see on our ABGs, and saturation as well, your SaO2, what we would see on a pulse oximeter. Hypercapnia is inadequate CO2 removal or ventilation. When you think ventilation, think you're exhaling CO2. So if too much of that builds up, that's deemed hypercapnia. We use our arterial blood gases, our ABGs. They are the gold standard that are going to assess changes in pH, PaO2, PaCO2, and bicarbonate. Pulse oximetry might be used continuously or intermittently, and this can give you like a moment in time explanation of what's going on with the patient. But again, those ABGs are going to be more indicative of what's happening at a cellular level with oxygenation. So here's a picture of a normal gas exchange unit. So acute respiratory failure is not a disease in itself. It's more of a symptom. So with acute respiratory failure, it usually accompanies something else, some other problem that's causing compensation in the respiratory system. So in this normal gas exchange unit, we can see we've got the pulmonary artery coming in, exchanging that deoxygenated blood for oxygenated blood, moving back into the pulmonary vein. And you can see that there's no blockages or no issues with that exchange taking place. So different classifications of hypoxemia and hypercapnia. So for our case study, we've got our patient here, JD, so a 75-year-old male with long-standing history of COPD. So admitted to the ED in moderate respiratory distress. Respirations is 32 and shallow, and he is anxious. So looking at this, you want to think, okay, so we know he's got the long-standing history of COPD, so that's potentially going to lead for chronic hypercapnia, chronic retention of CO2 from the inability to exhale that extra CO2. So when we look at his respiratory rate being 32, that would actually make you hypocapnic because CO2 is acidic. So anytime you're breathing too fast, you're trying to breathe out that extra CO2. So chances are at this point, if he was in hypercapnic respiratory failure, he is now overcompensating by breathing at a respiratory rate of 32. Okay, so moving on to our hypoxemic respiratory failure. So pathophysiology of this. So when you think causes of this, think VQ mismatch. So when they do a VQ scan, they're looking at the ventilation in the lungs. They're looking at how it's exhaling CO2, how that exchange is taking place. But then they're also looking, at the perfusion as well. So the normal lungs, the volume of blood perfusing the lungs each minute is approximately 4 to 5 liters. So if there's a problem with any type of perfusion issues, the lungs might be doing fine. The lungs might be able to exchange that CO2 for O2 with no issue. But if there's decreased perfusion to the lungs, then there's less blood. If it's not perfusing as fast, and there's less blood being oxygenated, being delivered to the rest of the body. So some causes of this would be shunt, diffuse limitation, and alveolar hypoventilation, which we're going to talk about all of these. So for shunt, this could be anatomic or intrapulmonary. So a shunt can be viewed as an extreme VQ mismatch. So the anatomic shunt occurs when blood passes through the anatomic channel in the heart, so like a ventricular septal defect, and just completely bypasses the lungs. So it doesn't, engage in gas exchange whatsoever. An intrapulmonary shunt is when blood flows through the pulmonary capillaries without participating in that gas exchange. So intrapulmonary, this is typically seen when the alveoli, when they fill with fluid. So if a patient is in ARDS, which we're going to talk about, or if they have a pneumonia, the difference being that ARDS is more generalized, it affects the entire lungs. So, that's going to be your your more severe case. Whereas with a pneumonia, it might only be blocking a small portion wherever that pneumonia has consolidated. But with both cases, we see fluid-filled alveoli that's preventing gas exchange from taking place, even though the perfusion is going through. Okay, so with diffuse limitation, and one of the things about the diffuse limitation is that with severe COPD, this can lead to hypoxemic, and it can also lead to hypercapnic respiratory failure. So COP kind of affects both. But as the patient becomes more end stage, then we're going to see more of the diffuse limitation with the COPD. So with this, any process with diffuse limitation, any process that thickens, damages, or destroys the alveolar membrane or affects blood flow through the pulmonary capillaries is going to cause a problem with oxygenation and ventilation exchange. So I do have a picture of that I'm going to show you guys. Another reason why this could be a problem is related to pulmonary emboli. So these clots that form in the lungs, those are preventing gas exchange from taking place. They're blocking blood flow wherever that is, wherever the area is where it's clotted off, it's blocking blood flow past that area. So if you have a severe like a major pulmonary embolism, it could potentially be affecting a big part of the lungs. Pulmonary fibrosis, like we see with late stage emphysema. ARDS, again, is going to cause this hypoxemia, interstitial lung disease, and then a hypoxemia present during exercise. Sometimes exercise-induced asthma can cause some hypoxemia as well. So here's diffuse limitation here. So you can see the O2 is being manufactured. There's nothing going on, nothing wrong with the oxygen. In the alveoli, there's nothing wrong with the blood being pushed through, but that that thickened membrane is making it difficult for that gas exchange to take place. So with hypoxemic respiratory failure, two of these things can be happening at the same time. For example, a patient with acute respiratory failure with pneumonia might have a combination of the two where they've got inflammation, edema, and hypersecretion of mucus within the bronchioles. So this would obstruct the airways, limiting our gas exchange. And then they might also have those alveoli be filled with fluid, causing that diffuse limitation where the gas exchange can't take place. Okay, so ABGs are back. We are going to be talking about partially compensated and fully compensated. So really make sure that you watch this video and you kind of refresh your brain about how to solve ABGs from second semester, as we do have our assignment with our ABG worksheet that we're going to be working on here. Okay, so our ABGs, let's kind of break it down and kind of elaborate on the video. So our pH, we want that to fall between 7.35 and 7.45. This would be considered a normal pH. Anything below that, anything below 7.35 is considered acidic. Anything greater than 7.45 is considered basic. For our PaCO2, we want that to be between 35 to 45. The difference with this one is if it's less than 35, they're considered hypocapnic. So if it's less than 35, they're going to be more basic. If it's greater than 45, they're going to be more acidic because remember your CO2 is an acid. And then that would put them as being a hypercapnic or acidotic. For our HCO3, our bicarb, we want this one to be between 22 to 26. So between that, we're looking at and bicarb is a base. So if it's less than 22, they're going to be they're going to be acidic. If it's greater than 26, then they're going to be basic. when we look at the problem is with the respiratory system, the metabolic system, the respiratory system is much quicker at helping to compensate, but it can only work for so long, whereas the kidneys are going to take a little bit of longer time to prevent the excretion of bicarb to kind of balance if a patient's in an acidic state. It's much more easy for a patient to breathe faster, breathe out that excess CO2, or hyperventilate to get rid of that extra acid that's in the body than it would take for the kidneys to, reabsorb that bicarb. So I'm going to go ahead and give you a practice problem here. So if we have a pH of 7.43, we have a PaCO2 of 28, and then we have an HCO3 of 18. So go ahead and pause this and try to figure that out. Okay, so the answer to this question that I gave you, this ABG value, so your pH is normal, okay? So anytime your pH is normal, you can say that and if your PaCO2 and your HCO3 are off, you can say that this person is fully compensated. However, when we look at the CO2 of being 28, that falls under alkalotic because it's less than 35. And the HCO3 is acidotic because it's less than 22. So how do we know if this is going to be metabolic acidosis fully compensated, or if it's respiratory alkalosis fully compensated? So how we know this, this is the only issue that you'll have with solving ABGs is between these two, is because that pH, even though it is normal, it's greater than 7.39, so it is slightly alkalotic, which means that the original problem was alkalosis. So we would call this as being respiratory alkalosis fully compensated by the means of metabolic acidosis. Okay, so moving on to our case study patient here, we've got a pH of 7.18, O2 of 58, CO2 of 60, and saturation of 85%. So when we look at his ABGs, they're indicating acidosis, severe respiratory acidosis. Looking at his pH is very acidotic, and his O2 saturation is showing hypoxemia, but he also has hypercapnia as well with the increase in the CO2. And so the cause of his respiratory failure we're going to talk about on the next slides. Okay, so hypercapnic respiratory failure is sometimes also called ventilatory failure. So this can be acute or chronic. Either there's an increase in CO2 production, or there's a decrease in the ability to adequately ventilate this extra CO2. So a patient who experiences sudden onset of decreased level of consciousness due to like a drug overdose may not ventilate properly. They might not be able to exhale that extra CO2 that they have. And this would be acute hypercapnia. Whereas a patient that has COPD, they might have it's kind of an insidious path between them having mild issues with hypercapnia and then eventually leading to end-stage CO2. So some causes of this would be asthma, COPD, also cystic fibrosis. Some CNS abnormalities, so drug overdose, brainstem infarction, or spinal cord injury, specifically at the level of C2, that respiratory center, might knock that respiratory drive because it's located in the center of the medulla. So if the medulla fails to alter the respiratory rate in response to changes in PaCO2, because your body is the most sensitive to CO2, if it's unable to control the respiratory rate due to a spinal cord injury or brainstem infarction, that could be a reason for your hypercapnia. Other spinal cord injuries that affect the respiratory muscles of the chest wall and diaphragm can also cause issues with hypercapnia or ability to manage secretions as well. So we have our flail chest, kyphoscoliosis, severe obesity, fractures, mechanical restriction, and muscle spasms. Any of these conditions prevent normal movement of the chest wall and also limit lung expansion. Our neuromuscular conditions, so Guillain-Barré, muscular dystrophy, multiple sclerosis, exposure to toxins, and muscle wasting of the chest. Now, muscle wasting of the chest, we see this a lot with COPD patients. The work of breathing uses up so much energy, so many calories. It's very tiring, and eventually, those muscles do begin to atrophy. Okay, so I talked about how it's really easy for the respiratory system to compensate for changes in ABGs. So if it's compensating for a period of time and that starts to fail, then we start seeing respiratory failure occurring. Mental status changes, ABG results are obtained if we see some mental status changes such as like restlessness, agitation, anxiety, perhaps some combative behavior. Later mental sign change would be, in confusion. Those all indicate inadequate O2 delivery to the brain. So other early signs, we might see some vital signs changes, some tachycardia, some tachypnea, mild hypertension. Late sign is cyanosis. So it doesn't typically occur until respiratory failure is severe. So our clinical manifestations, we might see a rapid shallow breathing pattern, some tripod positioning or pursed lip breathing. This might be used in an effort to blow off accumulated CO2. However, the rapid rate can cause some respiratory muscle fatigue, and this is common with asthma attacks. A change from a rapid rate to a slower rate is actually an ominous finding. This might be seen, in patients with acute asthma, meaning that progression of respiratory muscle fatigue has increased the probability of them going into a respiratory arrest. How we measure, when we take our vital signs, and you guys know that part of that is getting our respiratory rate and our pulse oximeter. Often what I see left out is going to be the depth and the effort. So the depth, is it shallow, regular, or deep? And then also that effort, which also is known as the work of breathing, or WOB. So if it's labored, if they're gasping, if they have nasal flaring, if you see retractions, and then the retractions themselves are really important because, subcostal retractions or your belly breathing, like that's normal, for example, in infants, but in adult, that would be an abnormal finding. And typically, the lower the retraction, the better off the patient is. If you're starting to see retractions that are supraclavicular, those uppermost retractions, that's an ominous finding, because if there's sucking in of the tissue on the throat, that patient is literally using every reserve they have from below the belly up to try to get a breath in. Retractions can also be like indicative of where the problem is too. So for example, intercostal retractions might accompany somebody with a pneumonia that's hanging out in the bases of the lung. We might see some retractions kind of in the lower intercostal area. Okay, so specific clinical manifestations, patient might have some dyspnea, and dys means bad, so bad breathing, might be difficult breathing, painful breathing. They might have a cough. We want to know if they have that cough, if it's productive of anything, is it chronic or intermittent. Paradoxic breathing, this is another ominous finding. This results from like maximal use of the accessory muscles of respiration, and this is when the abdomen and the chest move in an opposite manner. So you can go ahead and look at the example of that. And patient might also be diaphoretic, and again, this is almost like how somebody would even become diaphoretic from working out. It's the work of breathing that's causing them to sweat just from the effort. What are abnormal lung sounds? So we see crackles. This can indicate pulmonary edema. Pulmonary edema can also be accompanied by like a frothy sputum. Sometimes it might be pink tinged if there's also some bleeding going on. Hemoptysis is when a patient's, coughing up like blood tinged sputum. So loud crackles heard on expiration. This might be, increased lung secretions, might be symptomatic of pneumonia. Absent or diminished breath sounds might indicate atelectasis, pleural effusion, impaired inspiratory effort, and hypoventilation. Rhonchi is usually related to mucus, and usually it's heard upper if the patient's able to clear their own airway or, they're provided suctioning. Sometimes we can resolve rhonchi right then and there. And then pleural friction, there's a little clip of that one here that might also be heard like in the presence of pneumonia, but only if it involves that pleural space, the pleura. So we're going to do a physical assessment. We're going to see some findings that we saw, with poor circulation. Your patient might be pale, diaphoretic, might have some weak pulses, because if it's a perfusion issue, perfusion affects your oxygenation and ventilation as well. Chest x-ray can show some infiltrates or any types of atelectasis or chest wall abnormalities. ABGs, pulse oximetry, some CBC can give you your hemoglobin hematocrit, because if there's, hemoglobin is, what carries that oxygen. So if they have decreased hemoglobin, their oxygen, carrying capacity is diminished. So if they're, slightly anemic, they might have that pallor, that fatigue associated with that. Serum electrolytes to check for balance of those. Your analysis too, if a patient is severely dehydrated or not perfusing, they might have a scant amount of urine that we want to look at. Sputum and blood cultures as needed. And then some other additional tests we can, do is CT scan, that BQ scan, end-tidal CO2 detector, and that's typically used for, if a patient is intubated. Pulmonary artery catheter in severe cases, because remember the risks associated with that. And if pulmonary embolus is suspected, then CT scan or VQ scan will most likely be done for them. So patient with acute respiratory failure, we have to kind of determine what's going to be the best level of oxygenation and what type of delivery that we're going to be giving it in. So respiratory therapy is very helpful in determining what system should be chosen. So we look at it as kind of the levels of being a nasal cannula, high flow nasal cannula, oximizer, going up to a simple face mask. It has to be at 6 liters minimal. Anything less than that, patient wouldn't be getting the correct concentration of oxygen. Venturi, if you guys remember seeing those in first semester, we could do like a heated high flow, a non-rebreather mask, but those are temporary, usually used, in the interim before a patient's placed on CPAP, BiPAP, and then potentially intubated and placed on a mechanical ventilator. So those are going to be your different levels of oxygenation. So other things respiratory therapy are going to encourage is mobilizations of secretions. So the patient can, deep breathe and cough, making sure that they're getting adequate IV fluids, they're not dehydrated, and then humidification as well. And oxygen should be humidified. Anything greater than 4 liters should have humidification put on it. And even less than that, I have seen physicians order it for patient comfort. Chest physiotherapy, I have a nice little video of that. Airway suctioning, whether that be just oral pharyngeal, or if we're doing tracheal suctioning, either sterile or through a closed system through a ventilator. Frequent patient positioning, so making sure patients are being turned every 2 hours to kind of facilitate that lung expansion. When they're laying flat, secretions tend to pool, and then they also have to work against gravity to take a deep breath. And then ambulation as well can help. This is a picture of a patient doing tripod positioning to kind of open up the chest and facilitate that lung expansion and that removal of CO2. augmented cough. So if secretions are obstructing the airway, we want to instruct the patient to cough. And then we can perform this augmenting cough by placing our hands here as the patient ends a deep respiration, begins an expiration. We can kind of move our hands forcibly upward. Kind of reminds me of like a Heimlich, but for the lungs. So huff coughing, so this prevents the glottis from closing during the cough. Patients with COPD are able to generate, a higher flow rate, higher exhalation of that CO2 with a huff cough than with a normal cough. And then with a stage cough, the patient's going to be in a sitting position, going to breathe 3 or 4 times in and out through the mouth, and then cough while bending forward, pressing a pillow inward against the diaphragm. So this is kind of similar to, what we would do for a post-op patient when we're trying to encourage them to deep breathe and cough. So we want to make sure they're getting adequate fluid intake, keeping in mind, patients with your heart failure, it's going to be a risks versus benefits thing. Ideally, with adequate fluid intake, it's going to thin out those secretions and make them easier to remove. IV fluids as well, so PO, IV, humidification, using a mask, those are going to be less drying out than a nasal cannula would be, and then we can use some mucolytic drugs like acetylcysteine or mucomist, which is funny, that's actually the antidote for an acetaminophen overdose, but it also will help thin out secretions and help make them easier to remove. Bronchodilator too will open up those airways, and used in conjunction with a mucolytic can help secretion removal. So this video is a woman demonstrating how she would do chest physiotherapy, promotes postural drainage using a combination of percussion and vibration. We see a lot of use of CPT vests, common with cystic fibrosis. In children, a vest that actually simulates chest physiotherapy to loosen up those secretions. And then we had talked about suctioning as well, keeping in mind, the factors of how you perform suctioning. So positive pressure ventilation, so this can be non-invasive PPV, which is BiPAP and CPAP. BiPAP and CPAP can also be invasive if they're hooked up to an ET tube, an endotracheal tube, because they are modes that a ventilator can go into, but they're usually weaning modes. So we anticipate the patient's going to be extubated. We might put them on like a BiPAP, CPAP mode. And we'll talk more about this when we get into mechanical ventilation as well. Okay, picture of a non-invasive PPV, and this is a nasal. So for our drug therapy, we've got our relief of bronchospasms. So relief of bronchospasms, this is typically done with our corticosteroids, so methylprednisolone, Salumedrol or Salucortef, hydrocortisone are going to help with bronchospasms and inflammation. And these are used in conjunction with bronchodilators. Corticosteroids do also reduce airway inflammation as well. And then for diuretics, where patient fluid volume overload maybe has some fluid-filled alveoli, we can reduce that pulmonary congestion with some diuretics or heart nitrates, such as Tridil, nitroglycerin, if heart failure is present as well. With drug therapy, we've got treatment of pulmonary infections, so pneumonia, so we can give some IV antibiotics for that. The nice thing is if we're able to get a sputum culture, we can perform a culture and sensitivity and figure out what the offending organism is. So then that way we can choose the appropriate antibiotic for it. Reduction of severe anxiety, pain, and agitation. Got to be careful with these because any type of benzodiazepines or opioids, they do tend to have a sedative effect. But sometimes used in small doses, they can alleviate some of the anxiety, which patients feel when they can't catch their breath, and thus actually improving their oxygenation. nutritional therapy. So we want to collaborate with the dietitian to kind of determine the optimal level of feeding. Our goal is always to have a patient be able to use the PO route. If this isn't possible to maintain their protein and energy stores, their albumin, their total protein, and their lab values, might have to resort to more of an enteral or even a parenteral nutrition. Also provide nutritional supplements. It's very common for a patient that has some late stage COPD to have that, they might have that muscle wasting of the chest, appear cachectic, very thin, malnourished. They might have some boost or ensure ordered with their meals to kind of ensure that they get those calories that they need. For evaluation, we want to make sure the patient's able to maintain a patent airway with effective removal of their secretions. We want that respiratory rate, rhythm, breath sounds, depth and effort, adequate oxygenation, and then normal hemodynamic status as well. Some gerontologic considerations. So these are expected age-related changes. They're not going to happen to everybody, but just as kind of this is what happens with the aging process. We've got decreased ventilatory capacity, alveolar dilation, larger air spaces between alveoli, which leads to your loss of surface area, diminished elastic recoil, decreased respiratory muscle strength, and then decreased chest wall compliance as well. Some other factors that can lead to respiratory problems in the future: lifelong smoking, poor nutritional status, and then just less available physiologic reserve with cardiovascular, respiratory, and nervous system. So we're going to go ahead and take a look at this question here. So I want you to read through the question, read through the answers, pause this recording, and kind of think through and answer it on your own. Okay, so the answer here is A, and we're going to break down the question, go through the answers, and kind of explain why that would be your best choice for this patient. So our ABG results do indicate that the patient is in an acidotic state. We see that their pH is 7.31. It looks like they are hypercapnic. So probably hypoventilating with our CO2 of 50. Our PaO2 is very low, it's 51, and really we want that to be between 80 and 100. So with our HCO3 being 24, we could see that this is uncompensated respiratory acidosis. If our HCO3 had been greater than 26, it would be partially compensated because our pH is still abnormal, which wouldn't make it fully compensated. So moving on to our second ABG results, we see they're on 2 liters. Their pH is normal, it's still slightly acidic. Our PaCO2 is right where we want it. Our HCO3 has not changed, and our PaO2 has increased from 51 to 60. The most important thing to look at here is it's been a whole hour that this patient's been on the oxygen, and that we've got another ABG result, and that PaO2 is still abnormal. So we're definitely going to want to increase the oxygen flow rate to 4 liters, because again, this is the most indicative of the patient's status is going to be your ABGs. Documenting the findings in the patient record means that we're okay with it being at 60 and we're not going to be intervening. Repositioning the patient in a semi-Fowler's position, might be, helpful if the patient was supine in the beginning, but it does say that they are already in a high Fowler's. And then we're not going to jump to endotracheal intubation and mechanical ventilation for this patient, as they do seem to be improving with our O2 that we're delivering via nasal cannula. Okay, so looking at this question, which patient is at highest risk for hypoxemic respiratory failure? So again, take a moment, read through the answers, and go ahead and choose, what answer you deem is appropriate. Okay, so the answer for this one is going to be C. So every other answer are respiratory muscle paralysis, fractured ribs and a flail chest, and then slow breathing from a drug overdose. Those are all going to result in hypercapnic respiratory failure. The only one that's an actual problem with the gas exchange taking place and a perfusion issue as well, that VQ mismatch, is going to be your massive pulmonary embolism.